Let's welcome him.
Thank you so much for inviting me today. We'll be talking about regenerative injection therapies and their role in pain medicine. I just want you to remember these two quotes in front of you. The first one is, "A joint is only as strong as the weakest ligaments," by George Hackett. And the other quote, "Regenerative injection therapies completes what our body started with." Because we're going to need them later on. So prolotherapy is an old technique, but there have been some introduction in the 50s by this gentleman, Dr. Hackett. He was a trauma surgeon in Cleveland, and he saw a lot of patients in Second World War II, and he wanted to help them out by, stabilizing their pain condition here. So, according to the Webster Dictionary, the rehabilitation, regenerative injection therapies are the rehabilitation of an incompetent structure, such as a ligament or tendon, by the induced proliferation of the new cells. So I kind of compiled things here. This slide might look a little bit crowded, but really, if you want to understand regenerative injection therapies, you have to understand this slide here. So we have 7 techniques, all right? The upper 5 are the most important as far as we're concerned here. Osmotics, and this is represented by dextrose. Growth factors, represented by platelet-rich plasma and stem cells. Oxidative stress regulators, what we call right now prolozone, using ozone. Condor protection by using hyaluronic acid, اللي احنا بنسميها حقنة الزيت. Neuromodulation, and this is done by using dextrose 5%. Peripheral nerve regeneration using platelet-rich plasma, and myofascial release using dextrose 5%. These are the stages of healing: inflammatory, proliferative, and remodeling. As you can see, from the bottom of the slide here, I mean, this remodeling can, go up to 18 months. Again, this is how it looks like: inflammation, proliferation, and remodeling. These animal studies were performed by Dr. Hackett in the rabbit tendons, and he found that actually injecting proliferant agents can increase the diameter of the tendon by like 40%. Types of collagen, this could help you out understanding some of the like rare conditions like Ehlers-Danlos syndrome and Marfan syndrome, and which one you can help with and which one cannot. So we have 5 types of collagen. The most important one, as far as we're concerned, is number 1, which is present in bone, tendon, skin, teeth. We'll start with the stem cell therapy because it's the most controversial here. Now, there are a lot of misconceptions about using non-embryonic stem cells. These are not prohibited, by the way, because these are not the totipotent or pluripotent stem cells. So right now, these stem cells we're using, either we aspirate them from the bone marrow or the adipose fat tissue, are basically legal and FDA compliant. So what is a stem cell? It's a mesenchymal stem cell It's a primitive cell with the ability to self-replicate, differentiate into multiple tissues, fight apoptosis and reduce inflammation. Again, we have different types. We have the totipotent, pluripotent, and multipotent. Basically, we're using the multipotent. And we have three types, mainly adults, multipotent, bone marrow, aspirate, concentrate, and the adipose tissue grafts, or we call them the stromal vascular fraction here. We'll jump into the platelet-rich plasma, which is more available in Egypt here. So platelet-rich plasma contains growth factors. Basically, the most important of which is the platelet-derived growth factor. And these are like a fuel for any injured ligament or tendon to get rehabilitated. Evidence-based medicine has shown that PRP is useful in patellar tendinosis, lateral epicondylitis, what we call tennis elbow, osteoarthritis, high ankle sprain or muscle strain, grade 1 and 2. Okay, the ones that has more leukocytes are more useful in inflammatory conditions such as muscle and tendon injuries, while the ones that have poor leukocytes are useful for avascular structures such as joints and discs. We basically draw this blood from the patient and we put it in a centrifuge machine, and then we draw the platelet-rich plasma and inject it in the target under X-ray or ultrasound guidance. And these are basically FDA, compliance indicators here. Some of the articles, like PRP versus corticosteroids, PRP versus hyaluronic acid, and this one that I have a special interest in, PRP for peripheral nerve generation. This is a big topic, guys. And I want to show you just, it's in its beginning, but I wanted you to see these case reports here that we actually can heal the nerve from injury by injecting PRP. So this is an area of research for anyone that wants to really progress in this field. Beaton score is a very important score to depict, laxity in the ligaments and tendons. If you're above 5/9, you have ligamentous laxity. And the most famous one is what we call the benign joint hypermobility syndrome. By the way, it's present in about 10 to 15% of children and adolescents. And, I'm sure all of you guys have known someone that have this condition, but it goes undetected, sort of. And usually these children and adolescents, they have a lot of multiple injuries. They get worse down the years here because they don't get treated. Now, also ADS and Marfan syndrome are other examples of hypermobility syndromes, but we don't have time to talk about it. Anyway, we'll jump into osteoarthritis. So these PRP stem cells can help also early osteoarthritis here. As you know, osteoarthritis could be primary or secondary. This is a famous Killegren-Lawrence grading scale from 1 to 4. I always tell my patients, if you're grade 4, you're not going to get a PRP. It's not going to help you much. I mean, you must have, grade 4 basically is bone and bone, right? So you don't have much left over here in your joints to help you out with. But these could be helped with something like radiofrequency. Okay, so this is the pathophysiology of osteoarthritis. These are the from from Hackett book here, the Hackett referral patterns. And I wanted to show you the groin pain that we have here is actually related to a ligament called the iliolumbar ligament. This is the iliolumbar ligament. This is usually missed by most doctors here when they inject the sacroiliac. George Hackett used to love asking his fellows about this ligament here. Now I kind of gathered a program for sacroiliac pain, which is about 20% of low back pain. It's a very common problem. And I call them the 4D. First, to test for leg discrepancy. Then you do the Don Tegny exercises. You do the dextrose injection or PRP. And then you use the Don Joy sacroiliac belt. So by measuring between the umbilicus and the median malleolus and the SIS and the median malleolus, you'll be able to differentiate between true leg discrepancy from pseudo-leg discrepancy. And if you have a true leg discrepancy, you can benefit a lot from a heel lift here, okay? Don Tigny, this guy actually fixed my back personally, but he passed away a few years back. And there's a website, please look it up, thelowback.com. Don Joy sacroiliac belt. It's a little bit different than the usual sacroiliac belts, the abdominal belts that you see in the market here. They have like a couple of knobs that fits nicely into your sacroiliac joint. And then you do the prolotherapy. In old days, we used to do it, landmark techniques. Right now, we do it under X-ray, C-arm guidance. Okay, lumbar Z points, the zygophysal joints or the facet joints also. Also very useful for patients with, spondylolisthesis. You can actually strengthen the ligaments and the supraspinous, interspinous, and facet joints. And this could help patients with grade 1 to 2 spondylolisthesis, but not more than that. Of course, if it's more than that, you need surgical evaluation. The way we inject the ligaments in this situation, we go opposite to the spinal anesthesia here, where you go cephalad, because really you don't want to get intrathecally, So you go actually from above downward. Anyway, thoracic Z points, or thoracic zygophysal joints. Of course, nowadays we do this on the C-arm. These are the Hackett referral pattern for cervical and upper extremity pain. Cervical facet joints. As you know, C5, 6, and C2, 3 are the common sites of cervical facet arthropathy here. Now, another condition, very important, and it affects a lot of people, is the cervical instability. Cervical instability in the neck could be related to an injury and actually can cause quite a bit of impact on patients. Like, for example, it can cause spots, it can cause, because when you have cervical instability, you actually affect the vagus and the autonomic chain in front of the spine, of the vertebrae in the cervical area, and also can affect your vertebral vessels, and so it's really can basically give you all kind of diseases just from being unstable, and could be treated with PRP or dextrose. Barreau syndrome is one form of cervical instability. This is something, this guy, prolotherapist, they love talking about it in their meetings. I've seen it only once in my life, so I don't want you to think it's really very common. They also tried injecting the disc, TMJ. When we inject in prolotherapy or PRP, guys, we do a comprehensive injection, not like orthopedic guys where just they go and inject the joint. No, we inject the whole thing. I mean, we inject the ligaments, tendons, and cartilage and everything else. So this is some other injections in the, for tennis elbow, golfer's elbow, you know, the wrist joint, symphysis pubis. We see this a lot, by the way. Hip joints. Again, it's a comprehensive, you know, injection. As you see here, the effect of prolotherapy or PRP on actually improving the condition of the hip joint here. Again, these are mainly for early cases, guys, okay? The knee joint, again, before and after. Ankle joints. On this situation, on the right here, it's injecting with stem cell. Prolotherapy, I want to say, for the sake of clarification, in prolotherapy, we should just reserve it right now for dextrose injections, okay? So if you think about it, I mean, the ligaments, tendons, and cartilage, they're almost like avascular structures. So you really cannot heal them with, you know, training or whatever, like muscles. I mean, if you injure a muscle, you can always, you know, do physical therapy, do this and that, because it has a wealthy blood supply. But in these situations, you have to really provoke the tissues for an inflammation and help it to heal itself. There are two types, actually. You can inject the tendons or you can inject the nerve. And this is the upgrade of the work of George Hackett. And you can do this with doing what we call perineural injection therapy. You can do a caudal epidural with 5% dextrose. You can do deep nerve hydrodissection. You can even do trigger point injections with dextrose. Liftoff, this is how they pronounce his name. This guy is from New Zealand, and he developed a beautiful technique where he can inject the nerves by just very simple method, putting you know, dextrose 5%, you know, in the painful areas around the joint. And this actually can heal the tissues by removing what we call the chronic constriction injury, and by down-regulating the TRPV1, what we call the vanilloid receptors. And this is how it looks like in practice, okay? I do a lot of these, guys. This is a super simple procedure. Anyone can do it. Anyone that can inject in the subcutaneous area can do it. Deep nerve hydrodissection, this usually needs ultrasound to get the nerves and to inject the D5W there. And the theory behind it is you kind of release the nerves from, you know, from the adhesions around it. And this is just give you some literature from PubMed. Lateral femorocutaneous, what we call neuralgia paresthetica or carpal tunnel, done under ultrasound guidance. Sweet caudal, you can even do it landmark technique. You don't need, you know, anything for that one. I do it a lot, by the way, in patients with that have brittle diabetes. I found it extremely useful. Instead of injecting steroids in these guys and get you, you know, they can get you to like DKA, you know. This one from Korea, they actually did trigger points with dextrose. I do this a lot in patients that have neurologic issues like multiple sclerosis, where I don't want to use really local anesthetics. So I prefer dextrose. And it's actually was found to be more useful than lidocaine and sealant, according to this one study here. Okay, trigger points, you basically break the spasm here. Prolozone, it's another way to do prolotherapy, developed by this guy on the right here, Frank Schellenberger. He has a nice course in Nevada, and he gives you the machine at the bottom here. It's called Longevity. It's a Canadian machine. And their main indications is for trigger points, also for joint injections and intradiscal, you know, injections. And the way the ozone works, it's by activating the aerobic process, and it has an antimicrobial effect and also the expression of adaptive inflammatory responses. This is some evidence here in disc injections and trigger points, ozone discectomy. And this is basically a comparison between the three types that we talked about today, the prolotherapy and PRP. Hyaluronic acid is a form of regenerative injection therapies developed by Carl Mayer here. Basically, I want to say that it has an anti-inflammatory effect, chondroprotection, and proteoglycan synthesis here. And we found that the higher the molecular weight has been reported to work more superior than others. References, key learning point. Thank you so much.
Thank you, Dr. Ayman, for this wonderful illustrative lecture. And we now with the questions, if there's anybody who would like to ask a question for the speakers, Dr. Morgan.
Thank you very much for this lecture. It was really very illustrative. I want to ask, do you have any preference for the three regimen, like for the peripheral nerve, you prefer prolotherapy, or for the, what's your preference? When I use what, from your experience?
Very nice question. Basically, I do what's available, with me. I mean, sometimes I don't have PRP, so I do the dextrose. And if I have PRP, I'll do the PRP. I want to say that the research is still, coming. So we're not really sure which one works better than the other. Shall we inject dextrose or PRP? Nobody really compared the two techniques together. So this is really a huge area for research. So I really encourage people to work on it. So,
and you combine, sometimes you combine like ozone with PRP or whatever, or you don't use
Yeah, I mean, okay, ozone is the least evidence-based procedure out of the ones that I talked to you about here. Okay, so usually with ozone we have to add something. Usually a little bit of local anesthetic. Also we add some of these homeopathic agents like Trumil that has anti-inflammatory properties. Yes, ozone needs a little bit of a push when you do it, It's, when you do it alone, it doesn't usually do the job alone. But it does work.
Yeah, and when you use PRP, you add something like exosome, growth factors, calcium, or you just use the PRP?
Well, it depends on the availability of, things here. Like, for example, you can mix, for example, PRP with stem cell if you want to get better results.
Yes.
Yes, you can do that.
Yeah. Thank you.
Nice.
دكتور أسامة اتفضل.
Actually, Ayman, it's like you said, like ozone is one of the least evidence-based. I think Amr and myself, we are going to, because we use it a lot, and I don't know where did you come up with it is the least evidence-based, because ozone itself, it is effective. So.
I'm just saying, we don't have a lot of research, although I got you the ones that I was able to find here, from the literature. But we do actually have a lot of, we still need a lot of work on ozone. And actually up to now, in some areas of the world, they call it pseudoscience. I'm not saying it's not working. I'm just saying, we still need work. A lot of these things, guys, all the regenerative action injection therapies, they lack one thing, is the standardization. For example, PRP, We have all kinds of machines all over, these centrifuge machines that produce different concentrations of platelets. And thus, you cannot really tell whether it's working or not. Maybe my machine is not producing enough platelets to produce this, growth factors. And thus, you don't get good results. So that's why the area of regenerative injection therapies up to now in the United States is not covered by insurance. It has a potential. I'm not saying not, but it still needs a lot of standardization.
Right. And I have a question for Ikrami, please. So what is the difference between chordotomy and rhizotomy, the results, when it comes to results? Is it not like enough to have rhizotomy and the patient will be happy?
Sometimes rhizotomy can be controlled pain. So chordotomy is reserved for patients who are not responding to rhizotomy or medical treatment.
Yes, but my understanding is if you do rhizotomy, you are shutting off the signals coming to the spinal cord. So what is the difference? Why if it's not working,
rhizotomy means denervation of the nerve root. Chordotomy means lateral spinothalamic tract lesioning.
Yeah.
كبير جدا بين ان انا انجر اللاترال spinothalamic tract وبين ان انا اعمل rhizotomy.
Well, okay. So is it good for neuropathic pain as well?
So for neuropathic and nociceptive pain.
Both types
can be
of
used,
pain.
yes.
All right. Thank you very much. Cheers.
My question is for Dr. Osama Hamdi about migraine. While working in my clinic, I noticed that I have many cases of my recently developed migraine above the age of 40, especially in females. It's associated with somewhat rapid weight gain. Is there any correlation in literature? I didn't search it really, but I noticed it in my clinic. You find a female which is approaching menopause, she's 42, 45, like that. She started to gain weight rapidly, but she gained maybe 20 kilograms of weight in over 1 year or less, and she started to develop migraine with it. So is there any correlation like estrogen with migraine or a lot of adipose tissue with migraine? Did you read anything about this?
Actually, Ahmed, is interesting because I've just seen a couple of months ago a case with severe headache. It's not migraine or migraine-like headache, and bloating, and it was Cushing syndrome. It was a steroid, and although I ordered steroid blood test for it for the case, and came back normal because steroid has variation, diurnal and nocturnal variation. So I think the time they picked up the sample was normal, and I dismissed it. But he went to another neurologist, and neurologist insisted on performing a steroid level, and it was Cushing, obesity, headache, and some blurring of vision. Yeah. So maybe if you go down this path, maybe you're gonna find a clue. Maybe. No, Cushing. It was steroid producing tumor, suprarenal tumor. It was suprarenal tumor. Yes. Oh, okay. Yes. It's the second migraine. Oh, migraine-like headaches. Yeah. I think it's worth it to go down this road. Maybe we'll find a clue. Thank you.
Any other questions for the speakers? Dr. Sahar?
My question to Dr. Ikrami, if there is anesthesia dolorosa after trigeminal neuralgia treatment, ablation, is it logic to do tracheotomy for this patient to treat it?
Yes, for patients who develop anesthesia dolorosa, the only solution is trigeminal tracheotomy. So this is a solution for that patient.
Well, and what is the expected complication for this new guy?
Trigeminal tracheotomy is a safe a safe technique rather than cordotomy, because the trigeminal tract lies posterior in the cord, and the other tracts lies anterior to it. So it's safer than cordotomy at that level.
Thank you.
Any other questions? Okay, I'd like to ask Dr. Ayman, please. Dr. Ayman, what's the philosophy behind the use of dextrose in the injections? Is there any literature that said how it works? Does it have a local anesthetic activity? Does it have anti-proliferative function?
Well, it depends on the concentration of the dextrose. So if you go above 10% dextrose, like 10%, 12.5%, 15%, you actually get a proliferant effect. And this has been well proven by animal studies that was done by Hackett in old days here. Now, if you go to the 5% dextrose, you do what we call neuromodulation. You actually downregulate the TRPV1 receptors here, what we call the vanilloid receptors, which is involved in pain. And in a sense also, it frees these entrapped nerves at the level of the facial constriction underneath the skin. And this is the theories, that was put forward by Dr. Liftoff. Of course, there might be another theories in the future, but this has not been, shown by. I mean, there's a lot of research about it, but the mechanism basically is still a theory. We do not have something substantial that we can say that this neuromodulation occurs because of this or that. I hope this answers your question.
Yes. And have you come across any of the studies that's talking about the use of it for adhesiolysis or for lumbar or for failed back surgery syndrome, especially that you mentioned we used it for caudal?
Yes. There's only one big study about using dextrose 5%, for radiculopathy, doing what we call sweet caudal. And as I said, it's really a nice procedure, especially for patients with brittle diabetes, where you don't want to inject steroids. But really, no one really used it like. I understand where you're getting at here. I mean, it's not used like we're doing this RAX procedure where you put a RAX catheter, and I mean, nobody's doing this. Most of the literature, by the way, is coming from, rehab. And as you know, in the United States, 85% of the pain physicians are anesthesiologists and 14% rehab. And most of the literature coming from rehab is really very simple, straightforward, literature. So they just do what we call just an easy caudal, where they just stick a needle and they don't even manipulate the needle up or down, and they inject dextrose 5%. So it's still primitive, but anyway, it does work, and I usually use it in diabetics, brittle diabetics.
Thank you, Dr. Ayman. Thank you very much. And this comes to the conclusion of this session. I'd like to thank all the speakers for being